Hello to all my students. I am Dr. Utsav Bansal, Ophthalmology Faculty Marrow, and this is the awaited INI-CET November 25 Ophthalmology Recall session. Now, as soon as I have said INI-CET, you know INI-CET and ophthalmology means some curveballs thrown at you. And that is what we'll see in the questions that we discussed going ahead, that there were a total of 5 questions which were asked. And the distribution was skewed this time. None of the topics like retina, squint, or these common topics that INI-CET asks, they were asked. There were 2 questions from cornea, 2 from glaucoma, and 1 from optics. And as usual, one of the questions always is a curveball. This time also it was a curveball. But as you will see, all the other 4 questions were easily solvable. So overall, if I want to assess the ophthalmology part, I will say out of the 5 questions, 4 questions were easily doable. That means 80% of ophthalmology you could have scored pretty easily. And by INI-CET standards, I would say this was supposedly easy now, right? So let's start with our first question, which was asked. Again, please remember these are recall questions, so there may be a little variations. If there are, please feel free to tell us. Question number 1. A 30-year-old man presents with pain, redness, and photophobia. All right. He has a history of contact lens usage. Now, as soon as I hear contact lens usage, my mind starts working. An eye examination is shown below. Now, in the eye examination, what do I see? I see some kind of a keratitis, or if I can say so, corneal ulcer. I think my question gets solved here only, primarily at least. Contact lens usage with a corneal ulcer. But still, what they've asked, which of the following stains is used to stain the causative organism? Now, this is where the confusion can also come. Contact lens usage, we know, can cause corneal ulcer by either Pseudomonas, or it may also be a case of Acanthamoeba keratitis, right? So if we just see the question, there are 2 answers. But if we see the photograph, in the photograph, what can you see? A very simple and easy photograph. We can see that there is a ring-shaped ulcer or keratitis. Yes. So we know ring-shaped is more indicative, or rather more only indicative of what? It is indicative of Acanthamoeba keratitis. Okay. Ring-shaped ulcer. So based on the question, our diagnosis is Acanthamoeba keratitis. That's the ophthalmology part done, I hope. Yes. If not, then please remember that Acanthamoeba keratitis, the most common risk factor is contact lens use. Contact lens use with tap water or with swimming. Yes. But sir, tap water and swimming have not been mentioned in the question. I know they have not been mentioned in the question, but the image is showing ring-shaped infiltrates, ring-shaped ulcer. So I think it is pretty clear that the examiner is trying to ask you Acanthamoeba keratitis. Now the question comes, microbiology, how to stain the causative organism. So first of all, let us see what are the modalities through which we can diagnose Acanthamoeba keratitis. So first of all, clinical suspicion. As we have discussed, clinical suspicion, contact lens use, and we see ring-shaped ulcer. Okay. Then what can be done? What is 100% confirmatory is PCR, but PCR is not readily available. Then what we can do? We can do IVCM. What is IVCM? It is in vivo confocal microscopy. Again, it is one of the best things to diagnose, but again, not available easily everywhere. So then what we can do, as we have studied culture. If we remember how to do the culture, we know non-nutrient agar enriched with E. coli. We have to enrich with E. coli because it is a parasite, right? Protozoa. So we know we need something for it to grow. But the question has not been asked on any of this. They are asking you how to stain. Now, that is where you can say a little bit of microbiology comes into effect. So a lot of students who know microbiology may have been able to clearly straight away answer this. Acanthamoeba, how to stain it. If you were not able to do it, then what is the other way to do it? Then you could have ruled out. As I always say, in a question in which you are confused, try to rule out. Yes, let's see. We know that GMS stain is used for fungi. All of us know this. That means this could not have been true. Zeal-Nelson stain, we know it is for acid fast bacilli like Mycobacterium tuberculosis. This could not have been true. That means just by my basic microbiology, which I had read 15, 20 years back, I have been able to rule out two options. You are reading it every day. Yes, it would have been easier for you. Now only two options are left: calcoflower white stain or gram stain. What is the answer? Both are used or both can be used to stain acanthamoeba. So now here the question was, what was better? So that was the little confusing aspect, you can say. So we say how to diagnose, 4 points. Then the fifth point is microbiological staining. Microbiological staining, as we have studied, can be done by gram staining. In gram staining, what we will be able to see, double-walled acanthamoeba cysts, right? Everywhere the diagnosis is, when you are doing IVCM also, you are able to see double-walled cysts. But the problem with gram staining is that it is only having 60% sensitivity. And also, it cannot differentiate between the cysts and the trophocytes, right? These are the problems with gram staining. Then what do? Then we can do the calcoflower white stain. Calcoflower white stain is a fluorescent stain, so you have to see it under fluorescence. And in under fluorescence, what do we see? As again, we can see in the image, magnified for you, double-walled cysts. But the problem with calcoflower stain is also similar to gram staining. It has around 71% sensitivity. That means staining, whether grams or calcoflower, they are not the absolute foolproof methods to diagnose acanthamoeba. The better ways are PCR, IVCM, and culture, but they take a long time, right? And they are not readily available. That is why we needed to answer about microbiological staining. Now, sir, which would we have answered? So specifically, if they were asking you, then specifically microbiology says that calcoflower white stain should be the better answer, and that is why it was the better answer. Though if it was a multiple correct options, then both the stains can be used for the diagnosis of Acanthamoeba keratitis. I hope I am clear enough here. The answer, better answer I can say, would be calcoflower white stain. All right, everyone. Yes. Now, what if this was not the photograph? So if it was not a ring-shaped infiltrate which was shown, then it would have been Pseudomonas. How to stain Pseudomonas? Gram stain, obviously. Yes, that would have been the answer if it was a photograph which was showing a bacterial ulcer. Or better ways to find out Pseudomonas is that it is catalase positive, we know, right? Or we could have grown it in the citrimide agar. So those have been better answers, but still, if this question was only about stains, Acanthamoeba, the answer is calcoflower white stain. If it was a Pseudomonas image, then the answer would have been a gram stain. Right, guys? So not a difficult question, just a little confusing options and confusing answer if your microbiology probably was not up to the mark. Ophthalmology, easy. Microbiology, for me at least, a little confusing. For you, it should not have been. Right, guys? Done? That was our question number one, a simple question from cornea. Now, what else do we know about acanthamoeba? We know how to treat it. We know we can use PHMB 0.02%, or we can use the mouthwash, yes, chlorhexidine, or we can use propamidine. These are the three treatment options that we already know. Moving on to question number two. Question number two was probably the most direct, the most easiest question. Krukenberg spindles are seen in. Either you knew it or you did not know it, right? So Krukenberg spindles are seen in, yes, you may remember, as has been taught to you, they are seen in pigmentary glaucoma. In pigmentary glaucoma, we know that pigment gets deposited at various places. If it gets deposited on the corneal endothelium, those are called as Krukenberg spindles. But there was no option which stated a confusing answer. It was clearly given pigmentary glaucoma, right? What if pigmentary glaucoma was not given? If pigmentary glaucoma was not given, then we know that upon deposit on the trabecular meshwork, the pigments, they make kachra, like kind of garbage. So they block the trabecular meshwork and thus they cause secondary open angle glaucoma. So if pigmentary glaucoma was not given, then you could have answered the second answer as secondary open angle glaucoma. Right, guys? Please also remember that pigmentary glaucoma is more common in myopes, young males. Please also remember that the most common cause of secondary open angle glaucoma is pseudo exfoliation glaucoma. So if you have been reading your PYQs, you would see that in the past 2 to 3 years in NEET, INI-CET, lots of questions have been asked on pseudo-exfoliation glaucoma and on secondary glaucomas. Recently, a question on target sign was asked, an image-based question in the NEET examination, which was pseudo-exfoliation glaucoma. Before that, they had asked which is the most common cause that I have written of secondary open-angle glaucoma. So this is a topic which has been trending. So that is the power of PYQs. Once you are doing your PYQs, you know what the examiner is thinking, you know what are the important topics, you know what are the more likely topics to be asked. So please always do your PYQs. PYQs are important. They are not going to be asked straight away. You are not doing them for repeats. You are doing them to understand the trend that is going on. Right, guys? Let us move on to question number 3. Third question, again, a pretty direct, pretty easy question. A 60-year-old female comes with sudden onset of pain. It is associated with colored halos. I think this is the clinching diagnosis. Decreased visual acuity and a steamy cornea. Steamy cornea, basically, they are trying to say a hazy cornea. Just a different way of saying, I think. The pupil is mid-dilated and fixed. After reading 2 words, colored halos, mid-dilated and fixed pupil, I don't think anybody could have done it wrong. It was like everything was given, whatever you needed. IOP is 60. IOP is very high. What is the diagnosis? So much of information given. I think we can answer it straight away. Yes, the answer is acute angle closure glaucoma. Let's see what we have studied. We have studied as a sign of acute angle closure glaucoma that the cornea becomes hazy because of the high IOP, which breaks through the endothelium tight junctions and which causes corneal edema. Corneal edema causes colored halos around light because of prismatic dispersion of light. Yes, like the rainbow. Now we can see redness, we can see the hazy cornea, and we know because a lot of posterior synechia are formed. And because there is iris atrophy, it leads to the classic case of vertically oval, mid-dilated and fixed pupil. I hope you remember this. Fixed pupil because there is posterior synechia. Posterior synechia means adhesion between the pupil and the lens. So the pupil cannot move. Vertically oval and mid-dilated because the iris muscles have atrophied. So iris muscles have atrophied. So the pupil is neither able to contract completely nor able to dilate completely. So the pupil becomes mid-dilated. The iris muscle atrophies preferentially in the vertical poles, the upper pole and the lower pole. That is why the pupil becomes vertically oval. And that is the classic case of acute angle closure glaucoma. Now, the answer is pretty standard. We have studied it, right? We also know the treatment of acute angle closure glaucoma. What is the treatment? First of all, we control the intraocular pressure by giving IV mannitol. Once the pressure is controlled, we have to give pilocarpine eye drops to be able to constrict the pupil and pull the iris towards the center to be able to open the angle a little, followed by the definitive treatment, that is laser iridotomy, to create a hole in the iris to allow the fluid to flow from posterior chamber to anterior chamber. But if you had overthought in this question, then you may have landed in trouble. How? Sir, but option C is secondary angle closure glaucoma by uveitis. So, sir, angle closure glaucoma will again lead to all these things, sir. Couldn't the answer have been C? It could have been. But have they given you any specific feature related to uveitis? They've only mentioned a hazy cornea. If it was uveitis, they should have mentioned keratic precipitates. But sir, she's a 60-year-old female. We could have thought she has this disease, that disease. I know. But if a clear answer is given in option A, acute angle closure glaucoma, why would you think more? Right? Similarly, sir, couldn't the answer have been phacomorphic glaucoma? Phacomorphic glaucoma also causes secondary angle closure glaucoma. But phacomorphic glaucoma occurs due to intumescent cataract. Has anything been mentioned regarding intumescent cataract? No, nothing. So, in the lack of all these findings which have been given to us by other diseases, and the fact that acute angle closure glaucoma is given as an option, the clear answer is acute angle closure glaucoma. I would not probably have read the other options. right? Neovascular glaucoma, we know neovascular glaucoma is more commonly open angle, though it can be angle closure in later stages, right? So the answer was pretty clear. I don't think there was any confusion, and I hope you understand how easy question this was if you had just read this topic once, right, guys? Now moving on to question number 4. Again, an easy direct question. Given below are some tests for visual acuity. Which of these is used for a pre-verbal child? So pre-verbal child, we are saying basically less than 2 years of age infants, right? So again, I think a direct question. ETDRS chart, optokinetic nystagmus, Teller's visual acuity chart, and Landolt C chart. So we know Landolt C chart is used in adults who are illiterates. ETDRS chart, by the name it is saying it will use some kind of alphabets probably. You may know it as Bailey-Love chart. Bailey-Love chart was used by the ETDRS study when it was examining diabetic retinopathy. Yes, early treatment diabetic retinopathy study, and they called it ETDRS chart. So both the names are interusable. So if we know, this has been taught to us that for infants and pre-verbal, what is the first test to be done? Optokinetic nystagmus test. In optokinetic nystagmus test, we can use two instruments. One is the OKN drum and one is the Catford drum. As already explained to you, OKN drum has thick and thin lines based on the distance between or the thickness of the line that the infant or the pre-verbal child is able to focus on. We are able to understand the visual acuity. Similarly, for the Catford drum, there is different sizes of the dots. The second tests are preferential looking tests. We know an infant or a pre-verbal child will prefer to look at a striated area rather than a plain area. So that is why we are showing something which has striations and which has a plain area. And we know if the child can see, the child will fixate on the striated pattern. Now again, to know the amount of visual acuity, the striations start from broad and then they are made smaller, as you can see in the Keeler rating, from large striations to smaller striations or thinner striations as we go on. So this is Teller acuity cards and this is Keeler gratings. So we know both the options. Teller acuity cards is used and optokinetic nystagmus is used. That means the answer is option 2 and 3. That means the answer is option A, 2 and 3. Direct tests. I don't think there is any problem. Direct question again, you just needed to remember, or if not, then you could have probably ruled out also, right? Now, if you don't remember, this is what a Landolt C-ring test looks like. Landolt C-ring chart. And this is what is a Bailey-Love chart or an ETDRS chart, also called as the log chart. As has already been taught to you, this is not used, the Bailey-Love chart, ETDRS chart, this is not used in India. Indian medical education system does not use it. We use Snellen's chart, and that is why we don't commonly see it. The difference is between Snellen's chart and ETDRS chart or Bailey-Love chart, the fact that the number of letters here are constant. 5 letters in each row. The size is decreasing just like the Snellen's chart, but the number of letters are constant. If you remember in Snellen's chart, the number of letters keep on increasing from the topmost row to the bottommost row, right, guys? And that's your question number 4. 4 easily doable questions. Now we move on to question number 5, which was the curveball, I think, right? A 27-year-old male presents with myopic astigmatism. First clue. Comes with acute onset pain, lowering of visual acuity, that means loss of vision. He has a history of frequent changes of glasses and eye rubbing. An image of the eye just after a procedure is shown. Which procedure has been done? So now, which procedure has been done? Before that, what is the diagnosis? That's the key here. That is why it was a curveball. It was slightly something which we do not expect to be asked, very frankly. Okay. So let's see. They have given the clues to us as myopic astigmatism, eye rubbing. Eye rubbing, myopic astigmatism. We know eye rubbing can lead to keratoconus. We know keratoconus presents with irregular myopic astigmatism. We know keratoconus can lead to visual acuity decrease. But why acute onset pain? Why sudden lowering of visual acuity? And why a procedure has been performed? So, and there is some, in the photograph, there is opaque cornea or opacity of cornea. Keratoconus does not cause opacity in the cornea. So that means it is a complication of keratoconus, which is called as acute hydrops. So this question is basically on the complication of a keratoconus case called as acute hydrops. But do we know this? Do we study this commonly? No, we don't study it commonly because it is rare. Let us study it today. What are the causes of acute hydrops, first of all? But what is acute hydrops? So acute hydrops is when aqueous enters corneal stroma due to Descemet membrane break. The cornea is getting thinned out, the Descemet membrane breaks, endothelium is already broken, and that is why the fluid enters the cornea, causing an emergency state where there are higher chances of corneal perforation and the cornea has become edematous. Right? You understand? Acute hydrops, hydro, water. Yes? Now, what are the causes? Number one, obviously, corneal diseases. Now, corneal diseases can be classified in two groups, primary ectasia and secondary ectasia. In primary ectasia, we have three answers. Keratoglobus, pellucid marginal degeneration, so-called as PMD, and keratoconus. Keratoglobus means the whole cornea becomes more round, okay? So the curvature increases vastly. It's like a ball which is ballooning out. 11% approximately cases of keratoglobus lead to acute hydrops. 6 to 11% approximately cases of PMD lead to acute hydrops. But only around 2.3% of cases of keratoconus lead to acute hydrops. So that means if we are seeing primary ectasia, keratoconus is the least common cause. Right? Very rarely do we see acute hydrops. We see acute hydrops only in ignorant cases. Ignorant cases means patients who have not followed up with you, patients who are having problem, but they have not come to show, whenever. So they land up only straight away in an emergency. Otherwise, if a patient is showing commonly consulting, then keratoconus does not lead to acute hydrops. We are able to control it. Our medical science has progressed to a point where we are able to do the C3R and all those other surgeries to be able to prevent the progression of keratoconus. What about secondary ectasia? Secondary ectasia, we are saying post-LASIK or post-refractive surgery. If post-LASIK, if LASIK is not done properly, if post-LASIK the corneal stromal thickness becomes less than 250 micron, cornea becomes thinner, the damage is done, blah, 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 then also it can lead to ectasia. Or there can be other causes as written, congenital glaucoma or forceps-assisted delivery. These are the causes of acute hydrops. Okay. Now, why it was a difficult question? It was a difficult question because based on the image, they're asking you which procedure has been done. Now, as you would see, almost all the procedures listed on the screen in the options can be done to treat a case of acute hydrops. Let's see. So this is what an acute hydrops photo would look like. I'm showing you another photograph, right? Case of keratoconus, where the peak was formed in the center, and that is where the Descemet membrane has broken, and there is an opacity right in the center. Okay. Now, what is the management of acute hydrops? Management of acute hydrops says either it can be conservative. Most cases are managed conservatively, first of all. So what is conservative management? Conservative management says basic things. Hypertonic saline. Decrease the inflammation by giving topical steroids. Okay, this is what we are doing. To put pressure, prevent the perforation, place a bandage contact lens. In a lot of cases, we can conservatively manage it and do whatever treatment is required for the pathology, maybe like a keratoconus treatment. But if we need to do a surgical treatment, then what are the options? seal or approximate the Descemet's membrane and the posterior stromal tear. That is the initial surgical treatment. In this also, the most commonly done is intracameral air or gas. Intracameral means in the anterior chamber. Okay. Intracameral. I hope you know this. As taught to you in the mechanisms of routes of drug administration in the eye. Intracameral means injection in anterior chamber. Intracamerally, we can inject C3F8, we can inject SF6, but the best intracameral injection is C2F6 as shown by studies to us, right? So we can inject these gases, and that is what was option A, intracameral C3F8 injection. Intracameral C3F8 injection is given via a small incision in the cornea, which will lead to tamponading. Then we wait for a few minutes, we remove the gas. If needed, we again inject for a second time. Or what can be done? Compression sutures. We will put some sutures here to compress the fluid that is coming. We are compressing it, pumping it back out. Or what we can do, thermokeratoplasty or plasma injection, right? But a lot of times when we think that it has progressed further, it will not be able to get controlled by sealing or tamponading effect only, we have to replace the affected Descemet's membrane. Affected Descemet's membrane can be replaced by DSEC. What is DSEC? This is Descemet stripping, automated endothelial keratoplasty. The eye which is having acute hydrops, the endothelium and the Descemets are stripped. Then a donor endothelium is placed as a graft. The donor endothelium will produce Descemet's membrane and will lead to sealing. After you do DSEC to keep the graft in place. So see, this is my cornea. This is the graft I am placing, let's say. Now to keep this graft in place, I have to inject some air. Yes. So in DSEC also, we could have seen a photograph like this, where there was an air bubble. In intracameral C3F8 injection, there is a bubble. Obviously, it's a gas. So could both the options have been the answer? Yes. Now, was anything else given in the question? I don't know. If it was mentioned initial treatment, then there could have been an answer. If it was given some kind of keratoplasty was done, it was an advanced case, then there could have been an answer. But based on the lack of information, it was probably a case of whodunit. Whosoever asked the question, they had something in mind. They wanted a specific answer. I don't know what they wanted. Now, what about DALK, sir? So if you see, we can replace the edematous trauma by doing DALK. What is DALK, sir? DALK is deep anterior lamellar keratoplasty. Here we are replacing the epithelium, Bowman's and the stroma. Yes. So DALK could not have been the answer, because in DALK we are replacing the anterior layers. If we are replacing the anterior layers, we have to apply sutures. So if it had been a photograph of DALK, you would have seen something like this. You would have seen a normal cornea, you would have seen a donor cornea, and then the donor cornea would have had uninterrupted sutures applied, right? So DALK does not involve any kind of air bubble visible in the photograph. Air bubble is for keeping something posteriorly tamponading. Yes. So air bubble could have been visible in both the conditions, that is C3F8 and DSEC. Now, what is the answer that the examiner was looking for? I am not sure. But if I had to mark the answer, I would have gone for intracameral C3F8 injection. Why, sir? Because I think this is the initial treatment. A lot of times this only suffices to control acute case of acute hydrops or an emergency case of acute hydrops. Could DSEC have been the answer? Yes, sir. Could DALC? No, as I've explained to you. Could answer have been corneal collagen cross-linking with riboflavin? No, because this is a treatment for keratoconus and not for acute hydrops. But in all my correct mind, I would probably have left this question. But in another way, because I could rule out two options, if I could rule out option C and D, I would have to answer between only A and B, and it was a good guess which I could have taken either as intracameral C3F8 or DSEC. Both the answers are correct. Still, I am saying both the answers could have been correct. If it was a multiple correct option, then I would have answered A and B both. But as I have said previously, yes, AIMS does throw some curveballs like this. The examiner who is making the question, they may have done a study based on which they have given this question. So the correct answer from my side, intracameral C3F8. But for future references, what is acute hydrops? What are the causes of acute hydrops? And what are the management options for acute hydrops? All of these are listed for you. So as we could see in our examination, 4 of the 5 questions were easily doable. Yes, the ETDRS chart was easily doable. The glaucoma questions, both Krukenberg spindle as well as the diagnosis of acute angle closure glaucoma was easily doable. And similarly, the microbiology question on Acanthamoeba keratitis was easily doable. The only difficult, probably so as to say, question was the last question that we have discussed on acute hydrops. And I hope if you are understanding this, never focus on the ectopic question which can be asked. If we are able to do what we study, then we are good enough. 80% of ophthalmology, if you are able to solve. Similarly, if you are able to solve 80% of all the other subjects in an INI-CET, you are going to get rank 1. 160 questions correct, you are going to get rank 1 in INI-CET. And that is what our aim should be. PYQs are important. They are very important, at least the last 5 years, if possible, the last 10 years of all the examinations, NEET, INI-CET, and whatever questions you can find, so as to understand a developing concept of which topics are more important, what is the trend which is going on these days. Keep studying, keep watching videos, and best of luck for your upcoming examinations. Thank you, guys.